Hello and welcome to Season 2, Episode 92 of the Physician Assistant Exam Review Podcast. Today we're going to be finishing up GI with hernias and infectious diarrhea. All right, sorry, I have a 10-year-old and a 12-year-old boy, so anything in this category counts as funny for us here at my household. My name is Brian Wallace. I'm the founder and creator here at Physician Assistant Exam Review, where we help PA students dominate PA school and ultimately pass the PANCE and land their dream job. Hey, if you get something out of today's show, please share it with your classmates, share it with a friend. Help me get the word out. Help me help more people. If you found this helpful, then I think you probably know some people who will also find it helpful. And I just started an Instagram account. That might be a good way to share it, or however else you'd like. Just in conversation when it comes up that you found something that works really well for you for retaining information and you've learned a lot. That would really help me and obviously help whoever you share it with. So I would really appreciate that. All right. So today we're going to be finishing up with the GI tract. We're going to talk about hernias and infectious diarrhea are the two categories we're going to cover. So let's go ahead and jump right into our priming questions. We'll go ahead and get started. Getting ahead of myself. Define strangulated hernia. Define strangulated hernia. Again, the point here isn't that you necessarily know these. It's that you get your brain working. You start the blood flowing into your brain to help you retain more information. We're just like warming up a muscle here. Think it through. Even if you don't know the answer yet, let's pretend you're a pre-PA. You can think through this one. It's not complicated. A strangulated hernia. In what setting do you normally see Giardia? In what setting do you normally see Giardia? In what setting do you normally see C. diff? In what setting do you normally see C. diff? What I'm talking about here is where it's going to come up on a test question. Or what's the most likely presenting person going to, what's their story going to be? And what is the most important component in the treatment of infectious diarrhea? The most important component in the treatment of infectious diarrhea. All right, hernias. We're going to start with hernias today. And a lot of this is going to be definition driven to begin with. So first of all, what is a hernia? All of these things, I don't know why, maybe everybody out there, maybe you're smarter than I am. I struggled to really get what a hernia was, to understand what was happening. And I know we were told to feel for that little ring in the abdomen. I just didn't get it until I got into surgery and I started working with fascia and I could actually make an incision into the fascia and feel the ring they were talking about. So a hernia is the movement of an organ through the wall which normally contains it. So what generally we're talking about, especially with GI, is bowel pushing through into a place where it's not supposed to be. So for example, the easiest way to explain that would be if I take a trocar for laparoscopic surgery and I make a small incision in the skin, and then I push that trocar through the skin, through the fat, through the muscle, through the fascia, and into the abdomen, and through the peritoneum into the abdomen, I've created a tunnel all the way through, right? Now that is, if that tunnel is big enough, usually bigger than 10 millimeters is what we say, the bowel can come up through that opening in the fascia. So for surgical purposes, we will close that small hole if possible so that that doesn't happen. Those defects don't have to be man-made though. You can get a defect in the fascial tissue that will allow an organ to move through and herniate into an area it's not supposed to be in, just because that fascia tissue can become weakened. And I know if you haven't seen it and haven't worked with it, fascia can be a tough topic to understand, but it's a very thick, strong connective tissue that holds everything in place. So as you cut through the abdomen, it's a nice white tissue that you can put a suture into, and literally you could hold somebody up by putting a suture into their fascia, where if you put it into fat, it'll tear right through it. It's a very obvious tissue, but it does get weakened as people get older, and for different reasons, it stretches and becomes thin, or there is a congenital reason why the fascia may be weakened. So anyway, the idea is you have an organ pushing through into an area it's not supposed to be. A reducible hernia, let's start with that. What's a reducible hernia? Well, this is a hernia where the sac can get pushed back into place. An incarcerated hernia, incarcerated is where the sac cannot get pushed back into place. Strangulated hernia is a hernia whose blood supply has been cut off. Obviously, that's a bigger issue if the bowel that has pushed through to where it's not supposed to be is now the blood supply has been cut off. So think about it this way. If you have a big wide opening in that fascia and the bowel comes through, well, it's easy to push it back through the big wide opening. But if it's a little bit smaller opening, sometimes you can get stuck outside where it's not supposed to be. And sometimes not only does it get stuck, but it's such a tight squeeze through that it can cut off the blood supply. That's a strangulated hernia. Inguinal hernias make up about 75% of all abdominal hernias. And indirect inguinal hernias are the most common. This is the hernia sac that enters through the inguinal ring. Enters the inguinal ring through a congenital defect. A direct inguinal hernia protrudes through a weakening in the fascia of Hasselbalch's triangle. Femoral hernias have a high rate of strangulation. You can also get umbilical hernias because the fascia is a little bit weak near the umbilicus. You can get incisional hernias, and that's what I was talking about before. If you close the fascia but you don't do a good job, you can get a hernia that pokes through there. The bowel comes back up through. Or sometimes with those trocar sites, we don't close them because they're so small and so tight and it's hard to get at them. And generally speaking, at an 8 millimeter port, you don't need to close it because the bowel's probably not going to herniate through it. But it could. Could have a hiatal hernia, which is as the esophagus passes through the diaphragm, the top of the stomach can actually herniate up through the diaphragm into the chest. I get to fix those every once in a while. I don't do a lot of general surgery, so I fix some hernias in my practice, but not a lot. Where I work, we have residents who do most of the general surgery. So it's sort of a treat for me to get to do general surgery. I love the general surgeons at our hospital. They're fantastic, a lot of fun to work with, really, really good. And they teach well because they're used to working with residents. So it's always a pleasure to get to work with them. But like I said, the residents normally take those cases. Just to round out the idea of a hernia, you've all heard of a lumbar disc hernia, right? That's when the disc protrudes out from between the vertebrae and pushes against the spinal cord, causing problems. Right? It's a different type of hernia. We're not talking about an abdominal hernia there, but we're talking about tissue that's moved from a place it's supposed to be to a place it's not supposed to be. A cystocele is where the bladder protrudes into the vagina. Again, just to round out the picture in your mind of what a hernia is. Those aren't included on the list for abdominal hernias, obviously, but I just wanted you to get the idea. So clinical presentation, basically there's a lump where there shouldn't be a lump. Something bulging or poking through where it shouldn't be. Lab studies and physical exam findings. Abdominal films may show air fluid levels, but are not really all that helpful. A Doppler is going to be more helpful, and then a CT is the study of choice in most cases. Treatment, well, that's obviously going to depend on the type of hernia and what's going on. So if the area is inflamed, broad spectrum antibiotics may be appropriate. If we have a reducible hernia, then they can be fixed kind of whenever. There's no rush. So it's an elective surgical correction. Now, if you have an incarcerated hernia, it's a little bit different, right? Then we're talking about needing to get to the OR a little bit more quickly because we're concerned it could go on to be a strangulated hernia. So we're going to make them NPO, narcotics for pain, and then surgical repair. And a strangulated hernia is obviously a surgical emergency. Next, we have infectious diarrhea. Now this, I was kind of going to skip this section. I wasn't sure exactly how to handle it as a standalone for GI. I really would like to just leave it with infectious disease because we'll go through all these organisms there and probably go through them in more detail than I'm going to here. But I did think upon second thought, that sounds funny. I did think that I should spend a little time here and not just completely ignore it. Initially, I think in season 1, I just had a note that said, see infectious disease section. But I think it makes more sense for us to at least touch on them here. But what I am going to do is start with a broad overview. And you'll see why in a second, and it'll make sense. But for each of these, I'm going to be fairly short. So, infectious disease, or infectious diarrhea. Causes. Basically, there are three causes of infectious diarrhea. You have viruses, you have bacteria, and you have parasites. The viruses, the most notable viruses are the norovirus and the rotavirus. When we talk about bacteria, we talk about Campylobacter, C. diff, E. coli, Salmonella, Shigella, Staph, and cholera. Parasites, we talk about Giardia and amoebiasis. Now there are more, right? There are lots more, but that's as far as I'm going to take this. This is one bullet point on the blueprint. I'm not going to spend, I could do 10 pages on this. I don't think that's a relevant use of your time. So I'm going to cover these organisms. Are there more? Absolutely. Could I go into more detail? Definitely. But I don't think it's worth the payoff in this section because, again, we're going to cover some of this under infectious disease and under that topic. So, sources of infection: contaminated food, contaminated water, person to person, could be fecal oral. Clinical presentation: if we're talking about infectious diarrhea, we're talking, obviously the patients are going to have diarrhea, they're going to have vomiting, they're going to have abdominal cramping, they're going to have fevers, and they can have headaches. I'm not going to repeat those for each of these organisms, right? That doesn't make a lot of sense to memorize these separately. It's one of the things I talk about. If you memorize long lists for each of these, you're doing yourself a disservice. Memorize this short list and attach it to each of these, and you'll see as I go what I mean. So, clinical presentation for a patient with infectious diarrhea typically comes through the door with diarrhea. That makes sense, right? Vomiting, abdominal cramping, fever, and headaches. For lab studies and physical exam findings, most importantly is a good history. We're going to want to know if other people are sick, what they've been eating, if they've been around other people who are sick, where the patient is being cared for, where they live, what that environment is like. All that's going to be really important to getting to a diagnosis here. We're going to be looking for dehydration, symptoms of dehydration. So things like a rapid heart rate, loss of skin elasticity, dry mucous membranes, including the mouth, throat, nose, and eyelids. Low blood pressure, thirst, muscle cramps. A stool sample is going to be helpful, right? If we're trying to figure out why they have diarrhea, we're going to want to look at a stool sample. This, again, is not particularly something you need to memorize. This is something that should make sense. Think about it when you see a patient come through the door saying they have horrible diarrhea, vomiting, abdominal cramps, fever, and a headache. You're going to think to yourself, maybe I should get a stool sample, right? I don't think that's something you need to memorize as part of a list. Think it through. With that stool sample, there's going to be a couple of different things we're going to do to test it. We'll talk about them as we go. But certainly cultures make sense, depending on the situation, and a microscopic examination for parasites. So again, this is nothing new. This is nothing you need to learn. This is things that are already in your brain, so please use them. Right? If I just handed you a patient that said, this patient came in with bad diarrhea, that was their main complaint. List for me what you think the other symptoms might be. You'd probably say abdominal cramping. You might say vomiting. You might say nausea, right? All these things. If I asked you to describe to me what the patient might look like if they were in really bad shape, you'd probably describe symptoms of dehydration. That all makes sense. If I asked you for some tests you might order on them without knowing anything, you'd probably come up with, get a stool sample. You'd probably come up with, do a CBC. A BUN creatinine will help us here also as far as finding out their hydration levels. How about if I asked you, and here we go, let's just do this. Give me some examples of things we would use to treat someone with infectious diarrhea. Can you give me 3 things? Let's start with prevention. How do you prevent infectious diarrhea? Well, it's not complicated again, right? Wash your hands before you eat. Wash your hands before you eat. And that's the mainstay, right? And then you want to cook all of your food thoroughly. And don't contaminate food or water with feces. Next, if someone winds up with these conditions, what are we going to do for them? Well, number one, we're going to give the fluids. Fluids is the number one issue. What's really going to take someone down is being dehydrated. Fluids are the mainstay. I remember when the kids were little that was a big thing I pushed with my wife when the kids were sick and they'd be throwing up or have diarrhea or whatever it was. I didn't really care about any of it as long as I could get them to drink something, as long as you could teaspoon them some fluids, you could keep them out of the hospital. Typically, they wouldn't need to be admitted to the hospital as long as you could keep up with the hydration. So we're going to do fluids, electrolyte replacements, antibiotics, only in severe cases, and then something like odenocitron, which is Zofran for nausea or vomiting. All right, so let's run through some of these different causes. Rotavirus and norovirus, these two combine to be the most common causes of infectious diarrhea. There is a vaccination for rotavirus, so the numbers on that have actually gone down quite a bit. I think norovirus has taken over as the predominant winner here for most common because of that vaccination. Campylobacter is next. This is a gram-negative bacteria that produces a watery stool. Bloody diarrhea is possible, and it may lead to bacteremia in rare cases. This is a relatively common cause of infectious diarrhea, and you can use azithromycin if necessary. For C. diff, what are our risk factors? Long hospital stays and living in a care facility like a nursing home. So what happens here is antibiotics used to treat a patient for a different issue change the gut flora, predisposing the patient to a C. diff infection. Most notably, you have cephalosporins, penicillins, clindamycin, and fluoroquinolones that do this. The diagnosis is confirmed with stool testing. So either glutamate dehydrogenase antigen test, a C. diff toxin antigen test, or a PCR for the toxin gene. Vancomycin or fidaxin, fidaxin, I'm not familiar with that one off the top of my head, can be used to treat in severe cases. E. coli is a gram-negative, and this is the most common organism responsible for traveler's diarrhea. You can see I'm not going to take each one of these and tell you that they cause diarrhea. I'm not going to take each one of these and tell you that you treat it with fluids. Group that all together in your head and apply it to each of them. I'm just pulling out the things that make them a little bit different and that stand out on your exams. Salmonella is a gram-negative rod. It can cause typhoid or gastroenteritis. Here you can have bloody or purulent diarrhea. Shigella is a gram-negative facultative anaerobe passed along through the fecal-oral route. This is often found in daycare centers, nursing homes, and other places where conditions are crowded and sanitation is not great. Another interesting point here, or something that separates Shigella from the rest of these, is a patient with HLA-B27 may develop reactive arthritis. These patients can also have blood, pus, or mucus in their stools. And these have severe abdominal pain. They can have fever and tenesmus. Anybody remember what tenesmus is? This is a severe urgency to defecate. All right, just a couple more. Staphylococci is a gram-positive in clusters. You know these guys well. They cause what we normally call food poisoning, or colloquially call food poisoning. And food poisoning is simply in food that is left out and staph is on it. The staph grows. When the staph die, they release a toxin, which then sits in the food, and then you eat it and you ingest that toxin, which causes severe symptoms and can lead to fevers, diarrhea, really, really, really bad symptoms for, usually starts about 30 minutes after someone eats to about 8 hours after they have eaten the contaminated food. And they look like absolute death and they think they're going to die. And then suddenly the toxins clear and they come back to life and they look a whole lot better. It's actually really amazing. I've seen it a couple of times. One of my buddies in college and ate some pizza that he probably shouldn't have. And I've never seen somebody so green or bounce back so quick after the stuff cleared. It was pretty impressive. Cholera is another one, Vibrio cholera. This is a gram-negative bacteria, and it's common in places with poor sanitation and crowding. The toxins, cholera, the bacteria produces a toxin which results in hypersecretion of water and chloride. Now, these people produce a lot of diarrhea. So this is also known as rice water stool because it becomes so thin. We're talking about 10 to 20 liters or 3 to 5 gallons of diarrhea per day. So what do you think the mainstay of treatment is for someone with cholera? I hope you said fluids, fluids. These people are literally going to die if they don't get enough fluids. 3 to 5 gallons of fluid a day coming out is hard to replace. If you have some free time, The Ghost Map by Steven Johnson is an excellent book. It is about, I can't think of the year off the top of my head, and I don't, but it's about a cholera outbreak in London before they knew about germ theory. So they weren't sure if it was coming from the air, they weren't sure if it was coming from the water, and it was basically how Dr. Snow tracked down the outbreak to one water pump that had been contaminated with a fecal contamination from underground pipes. And that water pump, that contaminated water pump ended up killing a lot of people. And he tracked it down by basically figuring out who was dying from cholera and then using that to map out what those people were doing, where they drank from, where they went to work, all these things to try to figure out what was causing the problem. Really good book. I strongly recommend it. Again, The Ghost Map by Steven Johnson. Our next one is Giardia, which is a flagellated protozoan. This is a major source of transmission is from drinking contaminated water, including water from fresh streams that appear to be clean. The reason that's important is because on your tests, if you ever see a vignette that includes something about a hiker or a camper or someone who spends time in the woods and may have an opportunity to drink from a stream that looks clean but actually contains an organism that causes diarrhea, it's going to be Giardia. That doesn't mean in the real world it is, but it's a pretty safe bet on an exam. You can treat it with tinidazole or metronidazole. And then our last one for today is amoebiasis, which is Entoamoeba histolytica, which is generally transmitted fecal oral, and we're going to treat that with tinidazole or metronidazole. All right, and so without much fanfare, we will finish GI, and that'll be the end of that. So like I said, please don't memorize this section and go through and learn that each of these cause diarrhea, headaches, abdominal cramping, can be treated with antibiotics. You can go through and learn the specific antibiotics, but generally speaking, they don't get antibiotics. It's only in very, very severe cases. Instead, we're treating with supportive care, and fluids in most cases. You're looking for signs of dehydration. So think about the patient as they walk through the door and they have this problem, and you're going to either try to figure out what the actual problem is, or you're just going to give them fluids and hope they get better. And in most cases, they're going to, right? Depends. Obviously, things change though. If you're in a hospital setting with a 90-year-old who is medically in trouble to begin with, well, then you're going to go a little bit further to figure out what's going on and treat it. If you have a 10-year-old kid come through the door who's been complaining of stomach pain for a day and has some diarrhea, you're probably not going to be too concerned. You're going to take a good history. You're going to encourage them to drink fluids, but it's going to depend on that setting, right? It's going to depend on what's going on. And that's where the history is so important, because that's going to direct you whether or not you really need to look into this, whether or not there are more people who have this issue and there's a bigger problem on your hands, or whether it's an isolated case and it's really a non-issue. In a couple of days, the person's probably going to be better. All right. Before we get to the answers to our priming questions, let's talk about our study tip for today. This one's going to be pretty short, but something I think is extremely important. And it keyed off to me because I just finished Tim Grover's book, Relentless. And I don't know if you know Tim Grover. I did not before picking this book up, but he was the personal trainer who started his career by training Michael Jordan. He spent 15 years working with Michael Jordan, which says to me you probably should pick up his book and see what he has to say. In addition to that, he trained Kobe Bryant and he trained Dwayne Wade. I'm not a basketball guy, and those names jump off the page at you, right? Those are winners. Those are people who fight. He has a whole list of other players that he's trained, but those are the three that he talks about the most and builds the book around. And one of the things I always look for when I'm reading stuff like this is, how can I use what's in there to help you? How can I use what's in there? Well, to help me, quite honestly, first, but then secondly, to help you. What can I find in here that I can take away that might be helpful for you? And one of the things I talk a lot about, and I'm always happy when someone with a track record like Mr. Grover here agrees with me, is the idea of a pregame routine. It's something you hear about in sports all the time, and he really harped on it, that you want to practice your pregame routine before every game so that by the time you get to the NBA Finals, you can use that routine to calm yourself down and get into the zone so you're ready to get to work, to block out the rest of the world. But that routine has to be the same as it always is. And it has to be used when things are small, when they don't matter, so that it's effective once you hit the big time, once the nerves start to build. You know, one of the other people I heard a lot about and just kind of took this idea from was Michael Phelps. He had something like a 2-3 hour pregame warm up before he would swim. A well mapped out routine so that he would be extremely comfortable by the time he hit the pool. I mean, the guy's the most decorated Olympian of all time. Again, he's someone you might want to watch what he does and see if you can take something away from it. So what do you do the night before a test? What do you do the day of a test? You know, I had a very specific routine when I was in school that I think made a tremendous difference. I had a whole host of things I would do to help maintain my confidence and keep anxiety at bay. I know no one likes to talk about it, but testing anxiety is one of the major issues we have in getting through PA school and getting through the PANCE. I got an email the other day from somebody who had a complete panic attack during the second part of the PANCE and failed. Guy had very good grades throughout PA school, just completely lost it. It's not abnormal. I wish it were. It's not. It's very, very common. So think through, what do you do? What do you do before your exams? Write it down. Get a little index card. Write down, what do you do before your exams? I don't care what it is. I could go into detail and we could spend time on it, but I'm not going to do that here. You can come up with some things, whether that's long, whether that's short, to help get you into the zone and ready to take your tests. Like I said, there's a lot more we could go into down that path. I'm not going to go much further today. If you are looking to go a little bit further, though, with me and get that under control and get your scores up, starting on Thursday, I am going to be re-releasing the No More Test Anxiety package, which is getting an upgrade, which it hasn't gotten in a long time. It's getting an upgrade. So if you want to check that out, just go on, get into the email system, www.physicianassistantexamreview.com. Once you get there, it'll be very obvious how you get on the email list, and I will send you some information. What I do there anyway is send daily tips, tricks, techniques, things to get you through PA school. But in particular, starting on Thursday, I'm going to be relaunching the No More Test Anxiety package. And that if you're interested in improving your test scores and in battling with this and getting some control over that racing heart before you're enduring your exams, I have a whole lot of ways to do that. So we can go through that in that package. You can check it out there. Or actually, if you just go to www.physicianassistantexamreview.com/NMTA for No More Test Anxiety, NMTA. That'll get you information on that package as well. All right, anyway, let's finish up with our priming questions. Define strangulated hernia. Define strangulated hernia. A hernia whose blood supply has been cut off. In what setting do you normally see Giardia? In what setting do you normally see Giardia? Someone who's been hiking or camping or something along those lines. In what setting do you normally see C. diff? In what setting do you normally see C. diff? Here we're talking about a hospital or a nursing home, something like that. Again, not always, but generally. What is the most important component in the treatment of infectious diarrhea? And fluids. That's the mainstay here, the most important thing. All right, great. So that'll take us out on GI. We're going to be all done with that. If you're interested in the No More Test Anxiety package, www.physicianassistantexamreview.com/NMTA. Otherwise, if you could do me a favor and share the show. Again, I just opened up the Instagram account, so that would be pretty cool to see over there. And until next time, I look forward to hearing how your tests go and how your job hunt goes. Please let me know. I'd love to get those emails. Please let me know how all that stuff goes. It really keeps me going. All right, take care.